Okay, hi everyone. Hopefully you can access and see what's going on. Welcome to this first Pain Options live stream webinar on managing work-related knee pain. Hopefully you've managed to negotiate the technology and we're ready to roll. So we'll be delivering a presentation type format, as you can see here on the screen. And there's capacity to post comments, so if you want to do that during the presentation, feel free. Otherwise, I will actually pause at specific times for questions or comments, and we can deal with those as we go along. So again, thanks for joining us, and we'll make a start on the presentation. So we're going to briefly talk about guidelines, and at Pain Options we've been talking around guidelines for quite a period of time because the importance of those in terms of giving exactly that, a guide around how we should be managing musculoskeletal pain conditions. There's some difficulties broadly around guidelines though, in that guidelines may be made up by a consensus opinion, which doesn't necessarily hold a great weight of research or scientific evidence behind it, or they may be much more informed by good quality evidence if that is available in a specific topic or condition. Now, in terms of the concepts of guidelines, you're probably familiar with this term high value care, and really that describes this differential between what we call down this end as clearly ineffective services on the left towards on the right with clearly effective services. And obviously effective services are one that are ideally low risk and highly effective, and they may be cheap but they may not necessarily be cheap, but they might be the best treatment available. The difficulty is a lot of musculoskeletal pain sits in this grey zone section where there's a lack of clear distinction of what are the most effective services. So again, that's where the guidelines are important. So this Medicare benefits scheme review, this report's undertaken in 2016, and you can see then in terms of knees, on the do not do list of recommendations is arthroscopic debridement for knee osteoarthritis. Now that still only sits as a recommendation, so that treatment, although there's strong evidence in this instance to support its lack of efficacy over other treatments, that still exists as a Medicare benefit scheme schedule item. So we'll just talk you through a couple of guidelines. This one's the RACGP guidelines, and this is specifically for knee and hip osteoarthritis. And the two main ones are around land-based exercise, which is strongly recommended, and also weight management, which is again another strong recommendation. So those two things, when someone presents with hip or knee OA, are the two primary recommendations for management, along with appropriate education. There's also recommendations against interventions, so these include opioids, which we should all be well aware of by now, plasma injections, stem cell therapy, and as you can see there, arthroscopic lavage and debridement, such as meniscectomy or cartilage repair. So they're all strong recommendations against, but this is for in this instance, knee osteoarthritis. The other guide, which was released in 2018, is the Victorian model of care. So this is more broadly saying how care should be delivered most effectively for people with osteoarthritis. Interestingly, this recommendation around diagnosis says that OA can be diagnosed clinically by a qualified health professional without the need for imaging. So plain X-rays are only indicated if differential diagnosis is required or if you're planning interventions such as surgery. And again, in terms of the MRI scan there, it's not necessary for diagnosing MRI, but again, looking for more atypical or other pathologies. So these are the three components. Everyone with knee osteoarthritis should be given non-pharmacological care first, so not even necessarily medications. So non-pharmacological and non-surgical, so education as I mentioned, including reassurance, appropriate pain management, exercise and weight control. And then for some, pharmacological care can be added to that, and the first line is simple analgesics, such as paracetamol or potentially anti-inflammatories, and for a few, surgical care may be appropriate. Now, that's quite small, but broadly on this model of care with a holistic assessment of someone with OA, you'll note in terms of our pain option services, there's a range of different domains that we'll comment on in our reports, and they're broadly those ones there. So around social factors, understanding, occupational factors, mood factors, quality of sleep, other social or support networks, other conditions, their attitude to exercise, other comorbidities, and then the assessment of their condition. So broadly a thorough assessment to consider that all the different factors that might be contributing to someone's knee osteoarthritis. What we've done at Pain Options is take those guidelines and simplify them, and that's our Get the Basics Right information. So that's the one for hip and knee OA, and there's also one that's been developed around how to manage non-arthritic knee pain. So that's plain language summaries to help guide people of these are the basics of care that should be delivered if you're presenting with knee pain in general or specific knee pain associated with osteoarthritis. Okay, so that's a little bit of an insight into where the guidelines are at, and I know I've mainly focused on knee osteoarthritis there. I'll just pause for a minute to see if anyone wants to lodge any comment or questions on those. If not, we'll keep rolling through, and then if you post them up, I'll address them as they come up anyway. Okay. So we'll just talk a little bit more around osteoarthritis. And this information is around your prognosis of physical function. This was a study that looked at following an intervention, so medication intervention for assisting osteoarthritis. But importantly, if you look at this study, there was 303 people initially, and following the intervention, 41% improved, 47% no change, and 47% no change, 13% got worse with that intervention. Then they tracked these people for another 2 years with no intervention. So people then varied in what happened. So the majority here didn't change, majority here didn't change. The ones that had worsened, just over half of those has improved. So the course of osteoarthritis isn't necessarily this will get progressively worse. So some will, but others will improve, and others can stay stable at a level for quite a period of time. As we've mentioned, OA is multifactorial, so there is the local joint factors associated with that, and then on top of that, psychosocial and socioeconomic circumstances. Obviously work would come into that. There are other factors around physical activity, strength, and also pain sensitivity that can contribute to that presentation along with the structural pathology. That's why it makes it interesting, where effectively each case needs to be addressed individually to judge the effect of the different components that might be contributing to their pain. So this graph or figure here gives you a little bit of a representation around someone that has pre-existing OA and they might have some sort of knee injury. So OA tends to fluctuate as a condition, so people will have periods of being flared up, and then they'll also have periods of not being so sore. So if you think at this time point A, when someone's already in a degree of a flare, they could have a minor episode at work, which might be stepping down the step, being in a squatted position, changing direction, for example, or it might be a minor trip or fall. Then their knee gets flared up, and with that you effectively have an incident or a claim that occurs because of that further worsening of symptoms. So arguably you have an onset of symptoms during a period of perhaps already increased symptoms for the course of their knee OA. Versus at time point B, you might have a similar incident that really doesn't even register as an issue. A person might miss a step or have a slight trip and notice a little bit of soreness in their knee, but as expected, that settles within a day or two and no problems from there. So this study, the PACE musculoskeletal study, this is one that Darren Beals is heavily involved in Western Australia, but it's a national study across multiple states looking at different interventions around both knee osteoarthritis but also neck and back pain disorders. So some of the information here is from that study, and this importantly, as you're probably aware, is around the X-ray or radiographic severity of symptoms. So there is a very poor correlation between what shows up on an X-ray of a knee or an MRI of a knee and osteoarthritis symptoms. So as we've heard in probably other conditions before, what the scan shows alone is a very poor predictor of A, what's wrong, B, how much pain they're in, or C, what their prognosis is. So as mentioned earlier, radiographs or X-rays or MRIs aren't necessary for making a knee OA diagnosis. So you'll see listed there are typical features where we could see someone where we could diagnose OA clinically. So older age, describing when they're doing increased physical activity that they get knee joint pain. They might have some morning stiffness, but it doesn't last more than 30 minutes. There's often crunching or cracking, which we might call crepitus, when they're moving their knee. You can often see changes in the bony structures around their knee where things might be a bit more increased in size or knobbly or larger in certain points. The knee's not hot. There might be some degree of deformity, so varus valgus is in the alignment of the knee, so bow-legged for example, or the other way around, more knock-kneed. There may be signs of instability when we test them. When we palpate the joint, it might be tender of the knee joint, and also with the patellofemoral joint as well. So those areas of tenderness aligned with those other pieces of information, you can make quite an accurate diagnosis of knee OA. So in terms of imaging guidelines, it's not required for that typical presentation. If it's atypical, that may be necessary. So there might be rapid progression of symptoms where that might be necessary, or there's other atypical presentations such as a really hot or swollen knee, or if there was significant trauma involved, then the radiology may be more relevant. So if the imaging is required, then X-rays is the first choice. So what's called weight-bearing views, obviously when they're standing, to look for the alignment issues, and patellofemoral views to see if there's clear osteoarthritic changes on the patellofemoral joint. But as you can see down the bottom, we can't use that to predict response to treatment, including non-surgical treatment. So there's the list of the atypical features that may require further either imaging or assessment. Interesting concept around weight loss for knee OA, which has been around for a while, but there's increased understanding of this. So weight reduction of 1 kilo basically results in significant reductions in compressive load on the knee. Now keep that in mind, because we'll come back to some weight-bearing exercise discussion a little bit later, and that might explain why loaded knee exercises aren't always ideal for knee OA. What we also know is the effect of abdominal obesity on inflammatory markers in the system, so a combination of those things, both the mechanical load and increased susceptibility to inflammatory factors, can be relevant for people with knee OA who are perhaps obese or significantly overweight. Now this is a paper by some of the lead authors here are from Curtin University, but there's international authors on this as well. So 3 things around the narrative about knee osteoarthritis. So changing the message, changing the focus, and putting the patient in charge. This is something I'm sure you are all familiar with, and we certainly promote it here at Pain Options, because currently the things that we know around guideline-based care aren't being delivered in primary care. So many of the first contact practitioners that workers or patients are coming across aren't receiving this information. So around changing the message, there's a little bit of information around the myths and the facts, if you like. So around the degree of arthritis on a scan doesn't predict your pain and disability, rest actually isn't helpful, exercise is not dangerous, pain doesn't equal damage, and only surgery will fix it. Whereas the facts, scans are poorly related, rest and avoidance makes it worse, exercise is safe and helped at the right level, and 20% of people don't get any pain relief from knee joint replacement. So those facts are really important for people to know when they're making informed decisions for themselves around appropriate management for their knee OA. And as you can see, here's another graphic that really just describes the different factors that can contribute to knee health, if you like, and also knee function, which is why particularly muscular function, activity and exercise, and an appropriate understanding of what's involved for managing their knee are really important, but that's not the clear messages. If you speak to your family or friends about this, and it's probably worth testing what they understand about knee osteoarthritis, they probably don't know what it is, and they'll probably not hold those sorts of beliefs around what should be done in terms of managing knee osteoarthritis. And there's also listed in that paper what is low value and what is high value care. So this could be helpful in terms of decisions around approving management from an insurer perspective, but also guiding workers as to what should be appropriate care. So the graphics are really handy, I think, just to help give people greater information, based on what we know as far as current evidence around that area. This is another interesting infographic around meniscal tears, because that's a common one that you'll come across where there's a diagnosed meniscal tear on the scan. One of the questions is, was it caused by the injury, obviously, but then what management is required around this? So the current evidence, if someone has a degenerative meniscal tear, which is generally people over 45, but perhaps not even that old, it's not very old, 45 anyway, I don't think. So around exercise therapy, the outcomes are the same as arthroscopic surgery in terms of pain and function, and also functional performance. But muscle strength recovers better with exercise therapy than it does just with arthroscopic surgery. Then the other side of the scale, here we go, traumatic meniscal tears. If people are under 40 years of age, there's no clear evidence to determine the best treatment. So based on that, exercise and other non-surgical treatments are recommended unless the knee is locked. So arguably, even for people under the age of 40, unless they're presenting with a locked knee, which means their knee is actually stuck and they can't fully bend or straighten it, or they talk about periods where their knee catches and they really can't move it, exercise guidance is best recommended at this stage, in that there's less risks with that as opposed to other active management approaches. Sorry, I think I said that wrong. There's less risk with active management than there is with surgery, but we'll come back to that a little bit more. So other questions that often get asked in the community and also of workers, so development of arthritis following a meniscal tear. So this was a randomised trial, 140 people comparing exercise versus arthroscopic surgery. At 5-year follow-up, no difference. So that's pretty strong and very current evidence this year that if you don't have surgery, or if you do have surgery, the amount of arthritis in your knee 5 years later, based on this study, is not any different. So this is interesting around strength training versus neuromuscular exercise and education, and that's in people with knee osteoarthritis. So randomised trial, and basically higher load strength exercises compared to some of the exercises we'll describe shortly, there wasn't a lot of difference between those. Again, we'll come back to that. But what is really important, this is a review done in Denmark, where they have the GLAD trial, which is a big trial for delivering education, exercise and self-management for knee osteoarthritis, which is now international, also in Australia. What we know from that is the lack of information in primary care. So before people get assessed for knee replacement surgery, in terms of information about disease development, 63% said they didn't get it. Information about treatment modalities, 63 no. Information about self-management, 77% no. Lifestyle, 72. Physical activity, 45. And actually referred for physical activity, 61% said they weren't. About dropping weight, 49% said they weren't educated about that, and 64% said they weren't referred for assistance with weight management. And this is arguably in one of the countries with the best programs around managing knee osteoarthritis. So there's a real problem there still with the message getting through. Similar things, assessment of daily activity for a walking aid or other aids around the house. Pain assessment was low. A lot of people recommended paracetamol, which is appropriate, but still a third offered stronger painkillers, which isn't in the initial guidelines. And joint injections not offered so much, 76%, which is arguably fine, and information about the side effects of anti-inflammatories, just under 50% didn't get that information. Okay, any questions at this point? There's one question that I'll start with. If elective surgery is cancelled, will we see better outcomes? So essentially, that's happening at the moment with the current COVID-19 pandemic. So surgeries such as arthroscopic for knees will potentially be cancelled or have been cancelled, certainly in some hospitals already. Will we see better outcomes? Arguably, yes. But that also remains to be seen, because you could say from the guidelines, are those people getting appropriate information? And then in terms of that, are they doing appropriate management strategies around active exercise programs that are appropriately paced, and also education around weight loss? So if that's the case, then yes, the outcome should be better, but that's a real opportunity around sorry, I'm getting distracted by questions popping up. It's a real opportunity around the telehealth services that are being offered at the moment. So certainly if there's injured workers out there that are not getting surgery, they certainly need follow-up and regular input, probably somewhere between a weekly and a fortnightly basis, to help monitor and track the active management component of this. So it's arguably a real opportunity to test that. So next question, how do you find orthos managing people with OA issues with meniscal tears in workers' compensation outside of workers' compensation? So I think there's a difference in orthopaedic surgeon management inside or outside workers' compensation. This is only a personal answer of mine. I would say the difference in and out isn't necessarily that different, isn't that different, because there's a large proportion of private patients that we see that go on quite early to arthroscopic surgery still in the private sector that we'll see in the clinic. Arguably there might be a little bit slower to that in the workers' compensation system, because the insurers particularly, I think, are better informed and are perhaps asking more questions around, is guideline-based care being implemented? Darren's hanging out in the room, do you want to add to that? He's shaking his head. And the next question is, are the orthopods more ready to educate and send off for exercise? I think the short answer is some. So we've engaged in a hip surgery project here through Pain Options, where we've liaised with 3 of the hip orthopaedic surgeons in Perth, and they are very aligned with that concept, or they are aligned, some of them slightly more than others, but once the guidelines are described, they're aware of them, and as long as there's a clear strategy in place to give opportunity for providing appropriate active management, but setting a time frame on it, reviewing that at perhaps 6 weeks and 12 weeks, and judging, is appropriate exercise being delivered? And if so, if they're not better, then there's an argument maybe they need to proceed to considering surgery, for example. All right, very good. We'll keep moving on, but feel free to pop up other questions if you like. So now we're coming to the surgical side of things. This is a podcast, you've probably heard of Professor Ian Harris, who's an orthopaedic surgeon from Sydney. If you want to check out that New World podcast, pretty easy to pull up. He describes in layman's terms understanding around research behind surgery and the potential reasons why surgery is still being done in the face of some quite strong evidence that it is no more effective than conservative management for things like degenerative meniscal tears. So definitely worth checking that out. So there are guidelines around knee surgery. This is the Australian Commission on Safety and Quality from 2017. So With knee OA not responding to conservative management is offered timely joint conserving or joint replacement surgery depending on their fitness for surgery and preferences, and the patient receiving information about their treatment decisions. So again, that's quite broad. They're clear though, arthroscopic procedures not effective treatments for knee OA and should only be offered with true mechanical locking, as we've mentioned, or if there's septic arthritis in the knee or other investigations can't be undertaken and they need to do arthroscopic investigation of the knee. This is a study comparing arthroscopy versus conservative management with degenerative knee OA. So over the long term, patients have arthroscope versus those who receive conservative management do not have important benefits in pain or function. So again, that's reinforcing that. This one, knee arthroscopic surgery, middle-aged for meniscal symptoms, 5-year follow-up. So arthroscopy plus exercise provided no additional long-term benefit after 5 years compared with exercise alone. So there's strong evidence here, and these are important messages to share with patients and the general public around what the strength of evidence is at the moment. So this one is arthroscopic partial meniscectomy, and this is a systematic review, and basically for people with knee pain and a meniscal tear it's not appropriate and surgery shouldn't be considered as a first line intervention. So maybe some small to moderate benefit compared for physiotherapy in patients without knee OA. But this is often the defence. No trial has been limited to patients failing non-operative treatment or patients with an unstable meniscal tear in non-arthritic joint. So again, the definition of non-operative treatment, is that appropriate, and the duration of that. And an unstable meniscal tear is actually very difficult to define. That's why in broader guidelines a locked knee has been the definition. This is another very good paper around deconstructing the myths. So this looks into why is knee arthroscopy no better than placebo surgery. So you might have heard there's a number of studies being done comparing arthroscopy surgery to placebo surgery, and the outcomes of those are showing there is no difference. So the concept that meniscal tears cause pain and we can remove that damaged tissue has arguably been busted by these trials that I've just mentioned. So one argument is the meniscal tears are common in people without pain, of the general middle age and older population, and they may or may not have knee osteoarthritis. So they're often already there, then someone hurts their knee, investigations get done, so we blame the meniscal tear as the cause of symptoms. So in people with a knee injury, you scan the other knee and there's often meniscal tears in that knee. But patients get better could be a surgical argument. And some of those arguments are around, well, they might be getting better, but is it because of the surgery, or is it things like the natural cause or progression of the disease, which I talked about before, tends to show those fluctuations, spontaneous remission, regression to the mean, which if you keep measuring over time, things often revert back to a more stable measure of function and pain, and the placebo, where more invasive treatments create a higher response. So the power of that thinking I'm getting it fixed by the surgery also has a potentially powerful placebo effect. So this is the same paper we're still talking about now, where Thorland was involved in a study of 443 patients, and they tried to use the surgeon to assess the type of meniscal pathology, and you'll see those listed there. And surgeons will often say a different type of meniscal pathology has a greater urgency or need for surgery. And they also included other measures under arthroscope, such as the grade of cartilage damage, synovitis, and whether the anterior cruciate ligament was ruptured or not. Now, the things that were modestly related to worse symptoms were increasing age, female sex, and higher body mass index. But there was no clinical relationships between any of those actual definitions of type of meniscal tear or other structural pathology in the knee. So just going back to those, none of those listed types of meniscal pathology that are listed there correlated with the patient's reported symptoms prior to their surgery. So coming back to that Victorian model of care around hip and knee osteoarthritis, so there clearly is a place for surgical referral, but that needs to be a poor response to an adequate period of appropriate non-surgical therapy. And we often describe that as 12 weeks of appropriate graded active exercise rehabilitation, but we also need to look at the other contributing factors that might be barriers to that person getting better, which might be other general health or body weight factors or other work or lifestyle or even psychosocial factors. They would need evidence of advanced disease that fits with their symptoms, and we need to measure their pain and function and show that there's significant impact from those symptoms. The patient needs to be willing to consider the surgery and know there'll be a significant rehabilitation period afterwards. Again, saying not arthroscopic surgery, but in the context of more complex comorbidities, inflammatory arthropathy, large ongoing knee swelling or effusions or other red flag, then obviously medical specialist assessment earlier on is recommended. So the Australian Knee Society on Arthroscopic Surgery has a position statement around this, and this is from October 2016. So basically, the arthroscopic surgery has been shown to have no beneficial effect on the natural history of OA, and it's not indicated as a primary treatment. But in the statement, the door's left ajar because it does not preclude the judicious use of arthroscopic surgery when indicated. But as yet, there's no clear indications beyond the locked knee that we talked about that is currently supported for the arthroscopic surgery, particularly around the degenerative meniscal tears. Okay, we'll pause there and give you a chance, if you have any questions around that surgical aspect for knee pain, and particularly either the meniscal tears or the knee osteoarthritis. One of the questions we often get asked when we're asked to review patients with either degenerative meniscal tears or knee OA will be around, should this person proceed to surgery? And the 12-week appropriate exercise program is a big component of that. But the other difficulty we come across in that instance, if the worker comes in and they've had a scan which shows this tear on there, and they naturally correlate, okay, I've found the cause of my symptoms, and they've had an opinion, which maybe their GP or possibly they've seen a surgeon, and they've been told, you need to have surgery and this surgery will fix your problem. That's a common difficulty we come across, and the patient at that point, when we see them, can be quite difficult to shift in their thinking, even if they haven't tried appropriate conservative management, because they've been told, here we go, here's a quick fix for your knee, which is obviously naturally very attractive. So in that instance, we take the role of explaining the different factors that can contribute, and then suggesting there's nothing to lose by at least trying 6 weeks of an active exercise program, and perhaps if you're still not making progress at that point, then considering the surgery might be more appropriate. Now that can be effective for some, but it's certainly not effective for all if their beliefs are quite strongly fixed that they need the surgery to fix their problem. So again, that comes back to that early information around the first contact or the first few contact health practitioners that they come across, where that information is very powerful in setting someone's beliefs around what management's required. Okay, we'll keep moving on. So we're going to talk about exercise now, which is another difficult concept because, as you're probably well aware, a lot of people do get a lot of exercise rehab for knee problems and they don't necessarily do well. So the question might be, well, how does that fit? We've been told surgery is not required, but we've funded or supported exercise, and that might be 3, 6 or even longer months of funded exercise rehab, and they haven't really improved. So that's the difficulty from an insurer perspective, I guess, of trying to work out what do we do with these people, have they had appropriate management? So some of this input's from Darren, and I've been told that if you put lots of their credentials on the screen, it adds to their credibility. So thanks to Darren for your input there. So broadly what we know, exercise is good, But for any musculoskeletal condition, not just knee pain, no specific exercise has been shown to be better than another. So that becomes the difficulty in terms of recommending or approving exercise for people. So this is a summary graphic of the different exercise programs that have been suggested for knee osteoarthritis, and as you can see there's some degree of evidence behind a whole different range of exercise types. And arguably the most important thing for people with knee osteoarthritis is for them to engage in exercise. The type of exercise is possibly less important than if they're doing nothing to engage them in something as a first positive. So broadly getting people more active than they were has a range of positive benefits. If they're already active and exercise is causing them pain or not being effective, that's where we need to get more specific. And that's why one size doesn't fit all. So we can't have a standard exercise program that we say, this is what everybody needs. This is one of my favourite videos at the moment around exercise. So I'll just play this now, and it makes a little bit of a mockery of people getting carried away with their type of.
I'm all about kettlebells. Kettlebell training makes you better at everything in life, but mostly they only make you better at kettlebell training. Because kettlebells help you build less muscle than traditional bodybuilding exercises, they give you a better workout. With this exercise, I use 90% less weight squats, but my legs get a better workout because I'm holding the kettlebell in front of me, which gives me more shoulder activation.
So that's one of the issues with exercise, and I hear kettlebells have sold out of all department stores and exercise equipment stores at the moment, so clearly they are pretty popular in the exercise world at the moment, but they might not necessarily fix everyone with knee pain. So results for knee OA show that exercise reduces pain with a moderate effect, improves function, moderate effect, improves quality of life, small effect, and those effects are sustained over a 2 to 6 month period. And the guidelines are unanimous around, yes, we need exercise. So what do we need? Quadriceps strengthening has been recognised as perhaps the most important, and that is shown with improvements in pain and function, general lower limb strength, and also aerobic exercise. Now the mode of that tends to work better is individual better than group, which is better than home, but all of those modes can be effective. Obviously home needs to be effective at the moment given the current restrictions on access to supervised exercise or even gym-based exercise. Pool versus land are other different modes that could be introduced, and again there'd be reasons why that might be helpful for some and not others. And generally the pool-based exercise would be recommended if the person is really struggling to do exercise on land and they're getting too flared up. That's where the pool can be really helpful. But just if people do 6 weeks of pool exercise and they're not improving, that doesn't mean you then progress to land-based exercise for another 6 or 12 weeks. There has to be then questions asked as to why this person isn't getting better. So frequency, how often should people be exercising? So in terms of the strength exercises, they don't need to be done every day. Strength principles suggest they need to be done 3 times a week, and you need a day break in between. So there's a common error that people get given strength exercises and they complain they're getting sorer, and that might be because they're doing them every day, or it may be because their exercises aren't necessarily appropriate for their specific condition. Aerobic exercise, if you're doing moderate such as walking, you need to be doing that at least 5 days a week. If you're doing more intense exercise, so you might be doing running or interval type exercise on the bike or a cross trainer or in the pool, and you might be doing that 3 times a week. The obvious question there is around compliance, because if we say we've funded 6, 12 weeks, 6 months of exercise and they're not improving, there's a proportion of patients we see that they haven't been doing it. So then effectively they haven't had the intervention yet. But the compliance comes from our perspective with understanding. So why do you need to do these exercises? and engaging people in exercises that they're likely to do, so they can fit them in from a time perspective. They're confident with their exercises, they're comfortable where they're doing them. So for example, if people don't like going in a pool, they're not going to go in the pool. People that don't want to go to a gym shouldn't have to go to a gym. You can develop these exercises for them around what they can fit in and what they're comfortable doing. Then your compliance is likely to go up, along with having meaningful exercise provided for them. So I mentioned the Denmark program, the Good Life with Osteoarthritis program. So this has been running for a number of years with some positive research results in Denmark. So there's education of physios to deliver clinical guideline-based care. Then the patients get education in neuromuscular exercise, and then they collect and analyse the data. So it's a national program around implementing a consistent program and checking that it's been effective. So the aims: give access to guideline-based care across all health sectors and geographies, reduce pain, reduce medication use, improve function and quality of life, and reduce other healthcare costs associated with that condition. So we have the GLAD Australia program that you may have heard of. That's sort of been rolled out in more recent years, with a number of physios around the country being trained. So the process of that is an initial assessment with outcome measures being recorded, and note their functional outcome measures, so sit to stand and a walk test. Then there's group education of 60 to 90 minutes. And then they'll have 12 supervised group exercise classes, usually twice weekly. Then they get followed up. So that gives an example of a program which has been shown to have positive benefits, but again, that's been rolled out in other countries. We've had some discussions with people from Switzerland who are coordinating that at the moment, and interestingly, they've described some issues with compliance because people prefer different modes of exercise. So although the model's good, it's not ideal, and the data in Australia is still very preliminary. But that's an example of how a program might be run around knee osteoarthritis. So exercise errors, we've conducted an audit here at Pain Options of people that we've seen that have engaged in exercise rehabilitation, but they haven't done well with that exercise program. And here's the main reasons. The first one is people don't understand. So they've been told they need to do exercise, but they don't really understand why or what that means. The second one is that people exercise through pain, and that doesn't work well in two instances. If someone's got an irritated, swollen knee, and they're given this message that you just need to build up and push on, that will often just aggravate their knee. So that can be with true joint pain, where the amount of exercise isn't helpful. And the other end of the scale, where you've heard us talk before about pain sensitisation, if people are sensitised, then pushing through pain in that instance and not getting the amounts and the understanding right is important. The other one's not targeting impairments. So specifically, they might be given general exercise, but if they're really lacking quadriceps strength, for example, and they're not getting effective quadriceps exercises, they won't improve. The second part of that is then progressing that to function, and then the other error, as I've already mentioned, is compliance. Now I'm just about to share with you a video, and this is a worker that came through our Recovery Options Review program. He was a 57-year-old gent who was a baggage handler. Sorry, just lost the sound for a sec. He'd injured his knee at work, and shortly after that he'd had a scan and was diagnosed with a meniscal tear, and outside of guideline-based care, he underwent arthroscopic surgery for his knee within about 2 months of his injury and didn't have a good outcome. He was reviewed here at Pain Options about 8 months after his surgery and wasn't progressing well, even though he's had about 6 months of exercise rehabilitation. So I'll just play his video of his experience around exercise. So this is someone not so much with a sensitised knee, but with ongoing knee irritation and trying to push through with exercise.
Every time I've came out of the gym, it was swollen. Every time I've done the exercises, I was coming out there worse than when I walked in there. So that was giving me a real negative effect. of is it worth doing these exercises or is it worth carrying on with this because it's not working. So that was a very negative.
Sure. And how long did that go on for?
Probably 4 or 5 months, I'd imagine.
And what were you told about your knee's reaction to the gym?
I was saying my knees sore, and he said, that doesn't matter, just carry on with the exercises. I'm not worried about how sore your knee is, it's just strengthening up your muscles around it and that.
Did that feel right to you?
No. But I'm not a physio, so it's a workplace sends you to this physio, so I just had to, I thought, oh, well, just carry on doing it and it might get better.
Okay. Did it get worse?
I think so, yeah, because it kept swelling up. Well, you put me through a completely different program, I think. Started me with elastic bands instead of heavy weights and squatting, and which never helped me in the first place. You started me off with elastic bands, and slowly done it. Recovered slowly. Elastic bands, was no squatting, so there's no pressure on my knee going down. It was just strengthening my knee the other way. Yep, I can pick up 32 kilo bags now.
Yeah,
If
wow.
I bend properly, I've got a different technique. So I make sure I use the technique and squat down and lift it up.
Yeah.
And I can do that constantly during the day when required. And there's no strain, it doesn't seem to be half as much strain on my knee, just strengthens it. Yes, I can lift, I'll put that up to about shin height now and lift 30 kilos.
Yeah.
I've been doing quite regular.
Yeah.
And I've got a little bar in the garden that's only got 20 on now, so I can lift that up as well.
Yeah. That's
right from the ground, the 20 kilo one, yeah.
Yeah, good. Yeah, good. And whereabouts do you feel that when you do it?
It's in my hamstrings and my thighs.
Yeah, good.
But not pain in my knee.
Okay, so thanks to Steve Ranford, that was a patient of his, and obviously to his patient there who was quite happy to share his experience around exercise. You can see the key issue there was, well, he didn't get guideline-based care at the start because he ended up having arthroscopic surgery prior to undergoing appropriate conservative management. But then after the surgery, he did have arguably guideline-based exercise, but unfortunately the exercise wasn't really tailored to his specific requirements, so it wasn't effective. I think you've had a question come through, Darren.
Yeah, we've had a question. You quoted research regarding frequency and type of exercise. Can you tell from reports what they are doing in their exercise program, or do you rely on what the worker tells you? Should it be more transparent, and does the insurer need to know?
That's a very good question. So the reports that we see, and this is again only personal experience, so it may not be reflective of everyone, we don't always see clearly what exercises have been undertaken, so reports often are either absent or not very detailed around that, so that can be harder. We do rely on the patients, but the other side of that, a number of exercise providers, specifically more so the exercise physiologists, will have detailed exercise programs that the patient usually brings in on their phone, so we can review that. But then we will actually physically review their exercises, because it may look on paper that the exercises are okay, but either how they're performing them or the symptoms they're getting with them are different to what we might expect. So around the part of should the insurer know that, I think from an insurer perspective that's very difficult to judge or try to be on top of. The best guide for around that is, that's why we have outcome measures, and that's why we stop and check. And it's very simple. If someone's been doing exercise for 6 weeks and they're not improving, questions should be asked. That doesn't mean they're fixed in that time, but within 6 weeks it's highly reasonable to expect some degree of progress. And I'm talking usually in the order of 20+% progress in terms of pain and function. There'll always be exceptions to the rule, but there should be clear reasons for that. So as an insurer, I'd be asking after 6 weeks for changes or measures in function, both patient outcome questionnaires and some functional measures such as sit to stand or squat or walking tests and signs of clear progress. If not, then's a time to ask a question. There might be answers like this patient hasn't been compliant, fine, we've got to work on compliance. But if there's not a clear reason, things should be reviewed to some degree. That might be just with the exercise provider or physio, for example, or it might require an external opinion. Anything else you want to add on that? Okay, good. Now, the other bit, so we showed a video on true joint pain. This is, next 2 videos will look at poor knee function, and the first one is around lack of confidence in a knee and of beliefs around instability. So I'll just show you this video. So this gentleman has right knee pain, but in fact he doesn't have a lot of knee pain. He talks about his knee giving way and being unstable, and you'll see when he walks here, there's collapsing of his right knee or a sort of giving way of his knee as his weight goes on his right leg. You can hopefully see that reasonably clearly in a couple of those frames there. So he's been given an exercise program. I'll just play that once more. He's been given an exercise program but hasn't improved with it. But his barrier in this instance is confidence in his leg. So he's not confident to load his leg because he feels like it's unstable, and therefore his knee doesn't get any stronger, or his thigh muscles don't get any stronger. So the management for that is testing his knee to show him that it's not unstable, and then from there getting the appropriate strengthening exercises and confidence back into loading his knee. This next video is one of a low back, just to show pain sensitization in terms of allodynia. So you'll see with effectively 2 grams of pressure with a fishing line, you'll see no response on the left side of the back, and then an extreme muscle guarding response on the right side of the back. So when we talk about pain sensitization or allodynia, that's what's happening in that video. And of course, if someone's got that degree of response, then our orthopedic tests, which we'll demonstrate in a minute, they will be invalid because everything's going to be painful and sensitive. Or if they've got that degree of sensitization, you can imagine how much pain they'll be in if their exercise is ramped up too quickly and they don't understand what to expect with their exercise. So this is just a little bit of information around the influences on exercise, and we know about pain and pathology. Some people are more flexible or got greater capacity to develop muscle than others. People are very familiar with those parameters of strength and endurance, perhaps changing how people move, and then keeping in mind, particularly for older or other impairments where vision or balance might affect exercise, as might sensation, such as feeling under your feet with conditions such as diabetic neuropathy. But these other ones listed down the bottom, sensitization such as allodynia we've just talked about, beliefs or fear, thinking your knee's unstable, and things like body schema as well. So your perception of your body after injury or trauma or surgery can be relevant, and also other psychosocial factors. So for us, we find that is what makes treating these patients interesting, because they're all individuals and there'll be different factors that relate to how well they do or don't engage in exercise. Now that doesn't mean everyone needs this in-depth of an approach, because often it's very straightforward, get them strengthening, doing cardio and increasing function, and they go well. But for the ones that aren't, that's where we need to step back and look at the other factors that might be contributing to their limited recovery. So in terms of exercise with pain, what exercise do you want to do? How might your type of pain influence the exercise I need to do? Does it need to be specific or general? And then there's strategies to help with exercise. So that's a handout on our Pain Options website that we find is helpful to give people additional reading on top of the education that we've delivered for them So that might be something you might like to refer workers to, so they can gain a bit more understanding around what they need to be doing exercise-wise. Okay, I'll just pause again now. We're going to go through some physical demonstration of some testing. So hopefully that'll give you a bit of a clearer picture of the things we'll look at from a physical examination perspective. And we'll also talk a little bit more around exercise-wise, why loaded exercises such as squatting isn't always helpful, and what alternative exercises are available there. So I'll just show you these quick tests of sensitisation. So if someone's describing more widespread knee pain or pain that's really highly irritable and easily stirred up, we test this sensitisation to judge, are the other orthopaedic tests valuable? So we'll assume Steve's got a sore right knee. So Steve, we're just going to use a tissue, and I want you to compare on your left compared to your right. So if I brush on the left side there compared to the right, I want to know if that's obviously any different, as in do you feel it any more or less?
No, I feel the same.
So it's the same, so we'll just do that in a few areas. Any difference between those two?
No, I feel good.
On the outside, any different?
That's fine, yep, same.
And then down below,
Yeah, same.
so that would be testing for light touch or allodynia, and then we can use our toothpick. So obviously this will feel sharp, but the amount of sharpness, is that any different on that leg or not?
Same, yep.
And we might particularly chase where their symptoms are, so if they had medial knee pain, we'll just compare on this side, and is there any difference when I'm doing it on this side?
Same.
So we can do a quick screen. If their knee's sensitised, pretty quickly that's obvious. If you think about it, if I'm then doing orthopaedic tests, so I can do a test of Steve's medial collateral ligament of his knee by stressing it like so, and I'm interested in is there instability or laxity in the knee, but obviously also Steve's symptoms. Now if his knee's sensitised, that's all going to hurt, so it doesn't actually help me that much. So I could test the medial collateral ligament, then I can stress his leg on the other side and stress the lateral collateral ligament, and we can do both of those in a couple of different angles. Obviously if I was testing the medial ligament, I can then also palpate the ligament, which is helpful. There's a range of tests for the meniscus in the knee, medial and lateral. One of the most sensitive is palpation along the joint line, so palpating on the joint to see if there's clear joint tenderness for both medial and lateral. And there's other tests such as this one where we can load up the knee with more compression on the medial and lateral compartments of the knee, which is often quite symptomatic if there's a meniscal tear. The other important ones to be doing are obviously around the ACL ligament, which we can test for laxity in that forwards-backwards direction. We can do our Lockman's test, and we can do an anterior draw test, which we use for testing ACL, but we can also test posterior cruciate or PCL ligament as well. And there's other quick ones that we might do around, as you saw earlier. We can do just straight compression of the patellofemoral joint, and we can also palpate around the margins of the patellofemoral joint. So around the knee we can be quite accurate. If someone's got specific pathology in their knee, we can be quite accurate with locating where those symptoms are, and usually around the knee it's clearly localised to where their symptom description is if it's an individual structure, or if the knee's more broadly sensitive, the knee will be sore in a broader area but not necessarily tender in all those spots unless there's sensitisation going on. Okay? Then obviously we can assess the range of motion within the knee as well. So there are others, and we could go into more detail, but we can do a quick orthopaedic screen to reassure someone that their knee's not sensitised, and different structures that are commonly causes of symptoms. The other part around this is testing strength in the knee. So we can do an isometric quadriceps test where if you just lift your leg up and hold, Steve, and I can really gradually build pressure there. Now, a knee might be weak because Steve's got no muscles, poor fella, and then he just can't resist against me, so there's no power. But sometimes we test that and it's weak, but it's only weak because it hurts so much that he stops his muscles from working automatically. So there's weakness from true weakness, or there's weakness from pain inhibition. And for the same way, we could roll him on his tummy and test his hamstrings, we can test other hip muscles. Now, we'll just get Steve up to standing. I'll move the bed so he's standing in front. I'm just going to swing it around this way. I'll just come and stand over here. So a common one is squatting that we could test, and we might use something to hold on to. And if you squat down as far as you can, Steve, you get good information about joint mobility and ability to tolerate load just with a simple squat. Commonly people will report knee pain with squatting. If you just squat down to half depth and hold that, we can get a quick indication, is there muscle effort with this, or is there actually knee pain with this? If someone reports knee pain with this, then generally squatting exercises might not be helpful because they'll end up getting sorer rather than a muscle effort. Okay, come up to standing again. You sit in the chair. And then just come forwards. And that's why sit to stand assessment is so valuable. So just come up to standing again. So we can assess if someone gets knee pain with sit to stand. And if you just come and hold a squat there, Steve. How people squat and how people get up can make a big difference. If they don't transfer their weight far forward enough, so if their weight's back here, then they'll get more pressure usually on their patellofemoral joints, so they'll be describing knee pain. Just relax down. So someone who uses their hands on the handrest to get up and doesn't lean forward so much, they're going to load their knees. So sometimes that might hurt, but if we can encourage them to bend, lean right forwards and push up through their legs, we might be able to change their knee pain straight away. If that's the case, we still want them doing functional exercises, but in a different manner. So that's where loading through the knee joint can be modified by changing the exercise. But that's also why the wall squat, particularly if people have their feet a long way out in front of them and squatting down, that can often aggravate people's knee pain because again it loads the anterior structures of the knee joint. So it's a very popular exercise for some reason, but it's commonly unhelpful if your knee joint's sensitive. So with the patient that we showed on the video, they had been given these types of exercises which arguably will work your muscles if your knee's not too sore. But if your knee's too sore, that's not going to be helpful. So Steve, in that instance, I know, used some TheraBand exercises where we're saying to these people, we need to get your muscles working first, then we'll get your capacity to tolerate load and squatting later on. So Steve's just going to show us a couple of exercises that he would use. Yeah? Do you want to do the quads first, Steve?
Yeah. So as Tim mentioned, quadricep strength is quite crucial for DIY. Quite simply, if you don't have a knee extension machine or your gyms are closed because of COVID-19, okay, good. You can create your own knee extension machine with some TheraBand here. The focus on this is getting the grip around the leg right. If you just have it trailing on your leg there, you try and do your knee extension and it moves up your leg like that, not very effective. So instead, we simply twist, cross over the front of the foot, and that's anchored nicely around the leg, and you can start to do some knee extensions in seated position. Now with some people, you find a range of movement in which they're less painful. So my gentleman was quite sore towards end range, but he could initially work in that outer range with far less symptoms. So initially, to engage his quads in a less provocative way, we started in that outer range. As his strength improved and his symptoms reduced, we could then go full range. So you can easily get people to change their body position to get more tension in that outer range, or lean back and go full range with that knee extension. So quite simple. You could double the bands or try different ways to add more resistance.
Hamstring, purely just stand.
Yep. So hamstrings, you could do say a leg extension. So you might come into this position here, and then you've got your scooters like your Pilates reformer favourite. So you could do hip extension to work the hamstrings there. You could also, in sitting or standing, do some flexion, again, tucking under and doing some knee flexion there to work the hamstrings as well. That's probably a little more effective in a sitting position to work that outer range hamstring.
You don't need a specialist physio to hold the rubber all the time either. You can tie that off to something.
So 3 pretty straightforward home exercise options, but more importantly, as Tim said, it's the prescription of the reps to make sure that you're working within those strength parameters, and it's also ensuring that the patient is feeling it in their muscles, not their joints, making it sort of.
Very good. Thanks, Steve.
Straightforward.
Okay, we'll keep moving on. So we're just going to finish up. If you've got other questions there was a question about where I got my shorts from, but I'll fill you in later. They're kind of one of a kind. Good, back on over here. So what we'll talk about now, just to finish, is some additional information around progression of exercise and dealing with the more challenging patients that still require exercise. So activity pacing, you probably hear this term all the time, and there's a couple of approaches. One is operant, where basically you keep progressing and building your exercise or activity levels regardless of pain and fatigue. There's certain conditions where that's relevant, but generally with a lot of the patients we see that's not the approach. We would do the conservation approach where you're trying to reduce their symptoms by getting the balance right between activity and rest. So that's where you require careful education and guidance of their exercises. So you see these people that'll be pain avoiders, so they do a little bit of activity and it starts to almost get sore, so they stop and their conditioning really drops off. And you'll get the pain provokers or boom busters where they overdo activity when they feel good and then they're sore for days or even weeks and have to back off. They do the same again, but it's a net decreasing amount of capacity, so their function actually deteriorates even though they're trying to push on through pain. So they're the most common sorts. And graded exposure, and this is what it feels like for people, that there's a massive barrier in the way. Whereas to get to the same point, you can do that in smaller steps. So giving people understanding and control over that is particularly important. Starting point, Steve mentioned it. Too easy is no good, and we hear from patients often that they go, I don't know why I'm doing these feel like a waste of time, I can't feel anything with them. And the other end of the scale where people, it's too hard and either they get flared up or they give up because they're not familiar with exercise, so that becomes completely unhelpful. So targeting the function, not everyone needs a gym program. If you're working in an office, you don't have to get back to elite Olympic level fitness. So that's something that we as exercise providers, along with exercise physiologists, need to be clear on. And as I said earlier, not everyone wants to be in a gym. So the physical conditioning should be targeting their general capacity requirements for what they need to be doing at work. Obviously, broader fitness and strength is good for everything, but it must target their demands of work. So general functional training, and we talked about this with the sit to stand, so we're emphasising normal movement. Don't use your hands, don't hold your breath, don't pull faces to show us how much effort it is or how much it hurts, and get lots of feedback. So as Steve said, you want to be feeling this in your muscles, not actually in your knee. Once you give these sorts of cues, people get it, and if it makes sense and they feel like they're exercising rather than making themselves sore, that's where your compliance goes up. So we condition them using the principles we've talked about earlier in terms of 3 times a week for strength and 5 times for cardiovascular. And we use functional exercises that's relevant to their problem and reflects their problems as well. So it's the things that they can't do, we're trying to get them increased capacity in their ability to do that. Okay, just to finish, again, pop up any questions that you have at the moment, just before we finish up. I'm going to briefly talk around body perception. So it's kind of mental representation of our body shape or outline. So it can be a static shape or it can be with movement. So it has origins in Buddhism and mindfulness, but there's a fair bit of research being done in clinical populations like back pain, complex regional pain syndrome, where people report perceived distortion of their body. You can see in the picture here, the person's trying to visualise their leg, but their injured leg might be bigger or smaller or duller or harder to see or completely missing at times. So that's quite a common report. We did this research out of Curtin University a couple of years ago where we took people following ACL reconstruction and we asked them could they do this body scan. So out of 30 people, 29 could visualise their hand. So then of those 29, we got them to visualise their both knees, and 27 out of the 29 could detect a difference, either in size, clarity, colour, shape, or some other descriptors there as well. Then we measured their function, such as hopping distance and balance, and 25 out of the 27 that could detect a difference, once we gave them some exercises just for 5 minutes to improve their perception of their limb, 25 out of the 27 reported that their perception improved. But we also did these functional measures as well, and this one was horizontal hop. And about a quarter of the people that could do it had more than 60 centimetres improvement in a triple hop test immediately after doing that. So there's some seemingly correlation with changes in function when we get people to tune in or work on altering this body perception.
There's a question there.
Yep.
Is it similar to mirror box treatment?
No, it's not. So broadly the term graded motor imagery has been coined, and you're probably familiar with that, and that includes laterality training, so 3 parts. It includes that, laterality training, then graded motor imagery around visualisation, so trying to visualise the limb with movement, and then mirror box therapy is the 3rd part of those. So they're all angling at the perception of our body, but in different ways. Now, in terms of that, we would use body scanning in only a small proportion. I'd say less than 10% of patients that we see where it's relevant. It's like everything else. Not everyone needs medication, not everyone needs specific types of exercise, not everyone needs surgery, but some people have deficits in body perception, and particularly when they're very low level or highly sensitised, that can be an angle into reducing that sensitivity or normalising their capacity to function on that limb. So just coming back to this exercising with pain, that is a really useful handout that goes through those different concepts for people to read. So as I say, if you want to check that out or refer someone to have a look, feel free. That's it from our perspective, unless you've got any other questions for us.